Welcome and good afternoon. Today is Tuesday, February the 13th. I hereby call the Insurance Subcommittee to order. Madam Secretary, please call the roll.
Representative Sapicki, Himmer, Hicks, Hill, Kumar, Lafferty, Martin, Mitchell, Rudd, Rudder, Terry, Chairman Haynes.
Here.
Chairman Haynes, you have a quorum.
Thank you. Before we get started, are there any personal orders? Seeing none, we have 5 bills on the regular calendar and 1 on the addendum this week. First item, number 1, is House Bill 2445 by Representative Alexander. We have a proper motion and second. Representative, you're recognized on the bill.
Guess I better turn on. That's better. Sorry. Emma's bill is about a girl, basically in my district, who went away to college at the age of 19 and got a horrible virus, and now is basically an invalid and cannot communicate, nonverbal, has to have 24-hour care. She has to be turned multiple times. She has to be suctioned from a ventilator. Her parents have had to turn their home into a hospital room, and basically they watch her for 24/7. They had funding with TennCare and for her needs, but she had weaned herself from 12 hours on the ventilator down to 8. And because of that, their funding was cut. So now they only have care pretty much during the night so they can sleep. And they never leave her side. And it's just a situation that they came to me and asked if I would consider running a bill, not to help them, but they said to help anyone else who is in this situation. There are certain guidelines that TennCare goes by, and rightfully so, and they have different marks of how the funding is done. And this particular situation is, we're just asking that when you look at the determination of medical necessity, that you look at things like a patient's mobility or their ability to move or turn. You look at things like a patient's cognitive awareness and their ability to communicate. You look at a patient's need for constant nursing supervision and the patient's, and all, as well as the patient's need for a ventilator or other life-sustaining equipment. It just can't be the ventilator only, because there are situations where you have spinal cord injuries or the trauma to the brain from an infection that makes this impossible not to have 24/7 care. So that's what this bill does. And with that, I stand for questions.
Thank you. Do we have any questions from members? We do have Representative Rudder. You're recognized.
I don't have any questions, but thank you very much for bringing this bill, Representative Alexander. I know the family appreciates it. I support your bill.
Thank you.
Any more questions from members? We do have someone from TennCare. Would anyone like to hear from TennCare? I don't see anyone. Okay, we are ready to vote. All those in favor of sending House Bill 2445 to Insurance Full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to Insurance Full.
Thank you.
Item number 2 is House Bill 1939 by Representative Parkinson. Do I have a motion and a second?
Thank you,
Representative,
Madam
ready.
Chair Lady, for reminding my Democratic colleagues about the motion and the second, and my friends on the other side of the aisle. I appreciate it. Madam Chair Lady, I got a little concerned while I was standing up here.
You
but-
are recognized on the bill.
Thank you, Madam Chair Lady. What this bill does, it simply codifies that if a individual lives in a residence with a family member that they're caring for, they can still work for a 10-care provider and be employed by that provider. There has been a practice that said that, and I guess it was a policy through 10-care. That's what I asked, and they said it was a policy that an individual that is caring for a loved one could not live in the residence and work for a provider. And so they would have to either live next door, down the street, or around the corner. If they live next door, they can be employed by the provider. But if they lived in the residence, they couldn't. And that's just one of those policies that, made me scratch my head. And so what we're doing is just codifying in the law that, they don't, if they live in the residence, they can still be employed by those providers and still provide care for their loved one.
Okay, thank you for that explanation. Do we have some questions from members? Chairman Kumar, you're recognized.
Thank you. I think you're trying to correct a situation where just because the person can move next door or then they can get paid for the service that they're providing. Is that true?
That is true. Yes, sir.
Is there, where do we draw the line socially about I'm caring for an aging relative and I'm getting paid for it versus I'm doing it because of my love for the person?
You're recognized.
Thank you, Madam Chair Lady. That's a really good question, but I will say this, that I think you're going to get more out of a person because they're not having to make a choice to go and seek employment somewhere else, but they're employed while caring for their loved one. Additionally, in those hours when that same employee, had it been another person, had to leave and go home, this person is still going to wake up in the middle of the night unpaid and care for that loved one. So I think there's advantages here and opportunities here, but it just didn't make sense to me that if the person lived next door, the providers, they could work for the provider and provide the care, versus if they lived in the same house. It's still the same person that would be providing the care if they live next door, but they just happen to live in the same house.
Thank you. Thank you, Madam Chair.
Thank you. Representative Lafferty.
Thank you, Madam Chair. And I guess my question's a little bit along the same lines. If you've got somebody, I've got a friend back home, took care of his mom for a while. She had the paid for house. She had the paid for car. He was living in her house and doing what he could to take care of her. Same type setup. I've got a 9-to-5 job. Do I then get done with my regular 9-to-5 job, and can I get paid overnight while I'm sleeping at mom's house for being a caregiver? It seems to me like we're opening this up to a whole lot of new home health providers that may already be in that role, and we are kind of moving that cost from the family to the general public. Would you mind addressing that, please?
Yeah. Excuse me. So, and thank you for your question. Right now, the policy and the vehicle or the mechanism for that home health care already exists. We're not changing anything about that. All we're saying is that the individual can still live in the same house, or they can live next door or down the street around the corner also. But right now, under some of the policies, under I think the Choices program, they're saying that the person that lives in the house cannot be employed. We're not changing anything. We're not opening up any more budget. We're not opening up any more positions. It's the same amount of positions, same budget that providers have. Nothing changes. It just simply says this person is eligible too if they live in the house. That's all we're doing.
Chairman Lafferty.
So today, I believe that statement's true. My concern is in the coming months and years, we will have an explosion of people that are now not seeking gainful employment. And the system seems to me to be ripe to be manipulated a little bit is my biggest concern, but thank you.
Thank you. Thank you, sir.
Chairman Rudd, you're recognized.
Thank you, Madam Chairman. I think, let me understand your bill and exactly what it's doing. I'll tell you of a situation of a neighbor, which I think needs to be corrected, but we can't let it get out of hand. I have a neighbor whose child had a premature birth defect, who's a virtual vegetable. She had to quit for the last 17 years, she had to quit a job to stay home to take care of the child around the clock. I think she should be compensated to some degree because she's quit her job. She's unemployed. She didn't have another job, but the system will not pay her. I think that she should be paid since she has no other employment and she's strictly taking care of that child, and that child has a certain level of where he's permanently disabled. I don't think any parent or any relative, just because they're in the home or they're spending the night with them, should be paid. There has to be certain conditions that teen care would approve, and if they have no other employment. Now, the husband, on their hands, holding down 2 and 3 jobs to support the family. He's a teacher, and she's had to give up everything to take care of the son. And I kind of think, well, it's not really right that she's not compensated to some degree because she's doing what a caregiver would be doing. And I think the way your bill is written, I believe it's a little loose. It doesn't really define the level of care. And if it is, correct me, but the level of care, whether it's permanently disabled, whether the person has another job, or whether they're unemployed, I think it has to have certain conditions, but it just can't be for anybody that works for a home health care and has another job, or they're not permanently disabled at some level.
Representative Parkinson.
Thank you, Madam Chair, and thank you, Chairman Rudd. And now, under that scenario, if right now, based on policy, and this is not law, this is based on policy. Right now, she wouldn't be paid under the Choices program because she wouldn't be employed by a provider under the Choices program based on policy right now. Now, a stranger that lives next door or lives, a block down the street could be paid under the Choices program and come in and care for her child right now. That's what's set up right now. Now, we're not changing anything with how the providers train the people, how you qualify to work for the providers, this, that, and other. You still have to be employed by that provider to be able to provide that care, even if you were providing care for someone that you did not know. Right? There's no difference. The only thing that we're doing, and I don't want to overcomplicate what we're doing. The only thing we're doing is saying that if let's say there's an elderly person in your family and your nephew lives in your house, only thing we're saying is this nephew can go to work for the provider and provide care for the elderly person if he's hired by the provider. That's the only thing we're doing. But right now, if your nephew lives in the same house, he won't be hired. But if he lives next door, he will be hired. He can be hired. Let me say it like that. Not will. It's not automatic. So we're not adding anyone to the roles. We're not doing anything different other than saying it does not disqualify them because they live in the same residence to work for a provider. But that provider still has to decide to hire them, still has to decide to train them, still has to decide to make them a fit for their company to provide care. And if they don't work for the provider, they can't provide the care. We're not changing anything or adding anything to it. We're just saying that residence is not going to make you ineligible. That's it.
Chairman Rudd.
So your bill doesn't define the level of the urgency or the patient's condition. It's just anyone who is employed by a healthcare agency can take care if that care has been provided. In other words, we're not talking about permanently disabled. It could be a parent with dementia or someone who's recovery. But if they're employed by the agency, they can take care of them in that home. You're not defining the level of care or the condition of the patient, are you?
Representative Parkinson.
No, sir. We're not changing anything in the law regarding level of care, patients. If your level of care is that of a nurse and you're not a nurse, you can't do this. If the level of care that needs to be provided is that of an RN and you're not an RN, you can't provide the care. If it's that of a CNA and you're not a CNA and this provider it needs a CNA, you can't provide the care regardless of where you live. So we're not touching or tampering with what the providers say they need for this individual to be provided care. You still have to qualify to be able to provide that care. But if you don't qualify to provide that care, you can't be employed by that provider to provide care for your loved one in your house. You got to fit. You have to fit. We're not changing any of that.
Well, I think based on what Chairman Lafferty and others have stated, I think the fear is like right now, like daycare could be simple needs of bathing, just simple care for an individual. That's usually for a set like 8 hours a day. Then at night, the family takes care of them. It would have to be for that 8 hour period and not because they're staying in the home with a relative at night, because they normally wouldn't be provided services at night. I think if we don't put in your legislation some type of level, not of of course, they have to be qualified to work as a daycare person anyway, as someone who cares for it. But I think the fear is it would be abused, and people, even though they're qualified to be employed by the agency, they might be abused in the system. That's why I think it's important that if we do this, we limit it not based on the employee, but on the patient, that it has to be a level of care. And not every permanently disabled person needs a nurse. Parents give injections and feed and change and do other things like that and take care of the house in general. But it's to me, it's based on the level of the patient, not the actual employee.
Representative
Yeah,
Parkinson.
thank you, Chair Lady, and thank you, Chairman Rudd, and I agree with you wholeheartedly. But we have the oversight in place because the providers, if the patient needs a nurse, and let's say the nephew is not a nurse, he cannot provide the care. He cannot be hired for that patient. So the oversight is already in place. We're not changing any of that. We're not saying just because you live in the residence that you can be employed no matter what. That's not what we're saying here. We're just saying that if you live in a residence, it does not make you ineligible to become employed. That's all we're saying. So all of those things that you're asking about, and I agree, all of those things that you're asking about are already still in there. We didn't tamper with that part of the law at all.
Representative Hill, you're recognized.
Thank you, Madam Chair. I wanted to thank the sponsor for sticking with this concept. When you and I talked about this a couple of days ago, you said you'd been working on this for years. This is a deeply personal concern that government is not very good at being personal. And it's difficult. It's a difficult discussion to have on how family members can take care of family members and that interaction with TennCare and interaction with any type of pay. What I'm hearing is that the really the stopgap, the qualities, the standard, all of that is not really set to the individual. It's set to them being able to go to work for a care provider, correct?
Right.
And so if that's set in place, if someone that lives in the home is not the quality of what the provider would expect, they wouldn't get hired.
Absolutely.
And if they do something that they're not supposed to do, either with a loved one, or even if it was someone, across town or, down the street, whatever, then they would be fired.
Absolutely. And if you don't mind, just let me comment on that also. That person that's being employed, whether they live in a household or whether they live 2 miles from the person that they're caring for, is treated like an employee. If they are not providing the care that they are supposed to be providing to that individual that they're caring for, they'll be fired. Just like if it was a person that lived 3 miles from there, they're employees still. So yes, sir.
Representative Hill.
Thank you, Madam Chair. I think that your legislation attempts to also solve two other aspects. In-home providers, home health care providers who would be employing these individuals. It's not like they're at an excess of employees. And for these individuals that are in the home that would be a family member that could already work there, there's nobody that hopefully would be more trusted than a family member, but at the same time, you got a check and balance in place, which is good. And so I would encourage my colleagues to support this legislation. I think that not just your passion and really sticking with it, but you're trying to solve something that's a real world problem, and I'm grateful for that. So thank you,
Thank-
Representative.
Thank you for that. And Madam Chair, if you don't mind, just one quick response to that.
Okay.
You know, there are other programs in our state called Choices that do the same thing. That's operated through other providers. And those providers, they don't care if the person lives in the home already. They're already letting people, become employed by providers that live in the home. So we got one Choices program that says, can't do this because you got to live down the street. And we got another one that says, we let them, we'll take them if they qualify, we'll employ them. And that's what we're fixing.
Thank you. Chairman Hicks, you're recognized.
Thank you, Chair Lady and Representative Parkinson. Just to make sure that I'm clear, so currently, is this being practiced right now that they do allow this? So, right, because the fiscal note is pretty significant, but can you speak on where we stand right now with the fiscal note, which I think helps us to determine whether or not they're actually doing it now in policy? Could you speak on that?
I can.
Representative,
Thank you, sir.
recognized.
And the fiscal note has been updated to non-significant as of about an hour ago. Because once we explained to fiscal exactly what we were doing, they changed the fiscal note, and so it just shows you that there are no. It's not going to expand anything other than eligibility to be hired. That's all this bill does. It just simply changes eligibility to be hired by a provider. That's all it does.
And Madam
You're
Chair, and
recognized.
so just to be clear, so you're saying they do not do this right now, so they can't, because I guess I'm a little bit confused. So of course, this bill will allow them to, obviously, no doubt, but in policy right now, can they do that? So if someone's in the home, so can you speak on that?
Yes, sir. Thank you for asking that question. In the Finance Committee, when TennCare came before us, and y'all can pull the video on this, I asked, why would we allow strangers to care for our loved ones because they live in a different address, but we will not allow a person that lives in the home with their grandmother to care for their grandmother? And their response was, because we feel like they would do it for free.
Thank you, Madam Chair. Thank you, sponsor.
Chairman Sapicki? Chairman, you have questions? Okay. Representative Himmer, you're recognized.
Thank you, Madam Chair. I just want to thank the sponsor for bringing this. I know we're in a caregiver crisis here in Tennessee with our senior disability population. I've looked at some studies shows that we have nearly 60,000, or we'll have nearly 60,000 openings for home health and personal care aides in 2028 in Tennessee, which would be a 42% increase from the decade before. So appreciate you looking at innovative ways to fill that gap in here in our state.
Thank you, sir.
Chairman Terry, you're recognized.
All right, thank you, and I appreciate you presenting your bill. And just to get back to guardrails that are on this, and maybe to kind of clarify some other points. So the provider would have guardrails in there for employment of this individual. You're saying there's not a fiscal cost to this, but TennCare would put term, whether it's an 8-hour term or duties during that 8-hour term, that's something that they would apply to those patients already. And that's being provided by somebody that does not live in the home currently. Is that correct?
I want to be clear on your question. So right now, the providers already have their rules and their employment qualifications and everything that's already in place. So they hire people to be caregivers in homes right now. The only thing we're doing with this bill is saying just because you live in the home does not make you ineligible.
So
Chairman Terry.
thank you. So to my point is that they've already assigned some caregiver in that home for a certain amount. And now you're taking somebody that lives in that home and they're going to be the ones being the caregiver. So there's no additional cost, correct?
Absolutely correct.
All right. Thank you.
Representative Mitchell.
Yeah, thank you, Madam Chairman. I think Representative Hill alluded to it. You know, the need, especially in the rural areas, a lot of these are such low-paying positions that the cost of the travel, especially in rural areas, to be able to drive long distances to these locations where these folks are needed, it just doesn't make sense for people. And, you know, I have several friends who, you know, have home health agencies, and they're always just begging for help, but they can't get it because no one wants to do it in the rural areas. And that's where the need is the most currently. And the guardrails are, these agencies are not going to lose their state contract over just one person not doing their job. I can assure you of that. Thanks.
Chairman Hill.
Thank you, Madam Chair. It's a tremendous pleasure to be understood and comprehended by my urban colleague.
Without objection, we're going to go out of session and hear from Ashley Reed, TennCare, for clarification. Please introduce your name and who you're with, please, for the record.
Ashley Reed, Division of TennCare. I also have Katie Evans with me. I do think we need to clarify just a little bit of confusion. And for Representative Parkinson, I did just see the updated fiscal note that says not significant. Currently today, folks cannot hire their own family caregivers to provide care in the home that are not employed by a provider agency. And I want to defer to Katie to maybe help clear up a little bit of the confusion I think there is.
Please state your name and who you're with for the record, please.
Thanks, Ashley. My name is Katie Evans. I'm the Chief of Long-Term Services and Supports for the Division of TennCare. And Ashley's correct. So currently, provider agencies are not prohibited from hiring family members, individuals who live in the home, whoever they want. The provider agency has to ensure that that individual is qualified, is appropriate to hire, and then oversee them and the care that they provide to make sure the member receives the care that is necessary and appropriate. Where we don't allow caregivers to be hired as family members or in the family home is when we're talking about the consumer-directed services, where a family member is hiring someone to serve their loved one. So it could be that family member is hiring themselves, you know, hiring someone else who lives in the home with them to care for that member who also lives in the home. So currently there is no prohibition. Agencies can and have been hiring family members and other individuals who live in the home throughout the program for home and community-based services under the Choices program.
Okay, thank you for that clarification. Chairman Sapiki, I believe you have a question.
I do. Thank you. Thank you, Chairman. So this is already taking place, which would lead to the reason of not significant because we're just allowing a different group of people to be hired. I'm assuming that the commissioner would affect policy if we pass this bill to enact that to make happen, to also prevent fraud, waste, and abuse. And if there were any rules that needed to be promulgated, that would wind up in government operations for their approval.
Thank you for the question, Representative Sapiki. Currently, we don't have a policy on this. The language is silent, and provider agencies are not prohibited from making these choices. I mean, if we needed to make that more clear, we could, but it is no secret among provider agencies that they can hire family members, they can hire whoever they want that meets the qualifications to care for those members.
Chairman Sapiki.
So just to follow up, if we pass this bill, the commissioner will comply with the law. And if there's policy that needs to be created to allow these family members to be hired, the commissioner will do it, correct?
Yes, absolutely.
That's the question. Thank you.
Chairman Lafferty, you're recognized.
Thank you, Madam Chair. I was just curious, when we're talking about providers and provider agencies, we're talking about folks that contract through TennCare, is that correct?
Yes.
Okay, thank you.
Any further questions? We will now go back into session. Any final words, Representative?
Yeah, I want to thank TennCare, because we're simply codifying what they say they already do. Thank you.
The question on the bill. We're now voting. All those in favor of sending House Bill 1939 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full.
Thank you, Madam Chair, and thank you, committee.
Item number 3 is House Bill 2104 by Representative Dixie. Do I have a motion?
Thank you.
We have a proper motion and second. Representative, you're recognized on the bill.
All right, thank you. Thank you, Madam Chair. So just a quick question, quick show of hands. How many people right now go get an annual checkup for their annual physical checkup? Only 2, 3 people, 4 people? Well, we need another bill to encourage that to happen more. So basically right now we have state plans, insurance plans that pay for someone to get an annual checkup. And it provides for a relationship with their provider. This bill, what it does is it provides an opportunity for a mental health wellness examination for once a year, and it's paid for annually. This way, when someone is in a crisis, they're already familiar with someone in that role. So for instance, if I were to go to the doctor, I have a primary care doctor. I'm very familiar with them. Sometimes I may have a little pain here or there, but I'm more open to talk to them because we have a relationship. By this enacting this would have a mental health wellness examination once a year to determine, hey, how you doing? Just a checkup, just to see how you're doing mentally. And I think mental health is a big issue that's going on in our state right now. And we need to take it seriously. And I think this is the first step in making sure that everyone understands that they have this ability to have this.
Do I have any questions from members? Chairman Lafferty, you're recognized.
Thank you, Madam Chair. This looks a little bit like a mandate. And by the show of hands that we just had here, I haven't been to the hospital, to the doctor in a long time, and I pay premiums. If we put this on there, the insurance companies have to take into account the possibility that people will go, and then they would have to adjust premiums accordingly. Again, back to the show of hands, if we just use this as a small pocket sample, I'm not sure how many people, even if they're aware of it, that it's available, are going to take care of it, but I'm fairly certain that the insurance companies would make adjustments to premiums on the folks that are buying their policies. Just your thoughts?
You're recognized.
I have not heard any opposition from TennCare, any insurance company at all. It also says that if there's an increase in the fiscal note, if there's any increase, it's less than 1% of the premium. That's what it would be, less than 1%. And I think that's a small price to pay. You probably wouldn't even miss that. It's probably less than it's not even a cup of coffee right now. It's probably some change in your pocket to make sure that people have the access to a mental health professional on a regular basis. And then I apologize that because I don't know what I need to do to make you men go to the doctor more often, because I guess maybe I'm a little weird, but if something happens to me, I go to the doctor all the time. My biggest fear is for them to go to the doctor and they say, well, if you had just come in 6 months earlier, we could have fixed this. So, we need to stay on top of that. Men's health, you need to take it seriously. The women in here raise their hands. Gentlemen, we have to make sure that we take care of ourselves too, not only physically, but mentally as well. We all have a lot of stress on us. And this is just a checkup.
Chairman Lafferty.
And yeah, just you're right about us fellas being hard-headed and not going to doctors. There's no doubt about it, no secret. But the cup of coffee, I've made this comment in this committee before. I think each time we add a mandate, it may just be a few cents, but eventually a few cents turns into a few dollars with more piled on. And then a few dollars turn into lots of dollars. And we've already got a lot of folks in this state that struggle with the decision. Do I keep up my health care? Do I keep paying those premiums? Or do I buy food for my family, pay my electric bill, things like that? There's a lot of people that are walking a knife's edge that in this room we don't see a lot of. but they're out there. They're working class folks that are doing what they can to get by. And I just get concerned about the mandates that we put on the insurance companies. Thank you, Madam Chair.
Thank you. Chairman Kumar, you're recognized.
Thank you. Thank you, Representative. Two things come to mind. One, isn't that the current practice when a person goes for their annual wellness checkup and sees the doctor? At that time, medical conditions are addressed, as well as, I would think, in a thorough examination, mental health condition would also be discussed. And beyond that, if they need care, they would get referral. That would be covered by insurance, isn't it?
Yes, but there's a difference. You're a medical doctor, but there's definitely a difference between a mental health professional and a primary care physician. They're different things. So yes, even though a dentist can pull your wisdom tooth or maybe can give you a root canal, but sometimes it's best to go to a specialist that their job is all they do is root canals. Or a dentist can give you braces, but that's not their primary practice. So you want to go to an orthodontist to make sure that you get the professional care that you need. Not really sure. This is something that you can do. This is something, and you use the word mandate. I don't think the mandate is has a nasty connotation here. But at the end of the day, this is something that's going to help us get a handle on mental health and make sure people understand it's okay. Let's take the stigma away from mental health. And going to speak to a therapist.
Chairman Kumar.
Thank you. What I meant was that during a wellness checkup by the regular physician, family care or internist, part of that is a sort of a screen, how's the mental health situation. And if that person then needs further evaluation and consultation, they would be referred to a psychologist or psychiatrist depending on their needs. And that would be covered by insurance.
I think that I want to agree with, I'm sorry.
You're right.
I agree with you. It is covered with that. But sometimes we know that the business of a primary care physician, they rush them in, they rush them out. They don't spend a lot of time with you. And it's easy to cover your mental issue up in your 15-minute visit with your doctor. But if you're sitting down with a mental health professional for 45 minutes, where you can kind of decompress, talk to someone about what's going on, I don't see how this couldn't help that.
Chairman Kumar.
Your doctor is not going to be happy with you if you're saying that he rushes you in and out in 15 minutes next time you go to see him. Also, the Federal Mental Health Parity Act, does that not have influence or cover the situation?
It does. And good, let me just for the record, in case my doctor does watch this, he does take his time with me. And,
Okay.
we do have a relationship. We have a really good relationship. I actually have his cell number in my phone. So if something goes wrong, I can always call him and text him. So I have, better than telehealth, I have text to help. But yes, the Mental Health Parity Act does cover this and the cost sharing requirement. So this would just be along with what we're doing on a federal level.
So it is already covered under the Mental Health Parity Act.
Yes, it's one of those things as you were talking about with the previous piece of legislation. Is probably already doing it, but it's just not codified.
Chairman Kumar.
Well, I guess the natural question will be, if the Federal Mental Health Parity Act covers this situation and it is required, then kindly tell us why we need this legislation.
So especially, I would just kind of throw this back on you a little bit. We always worry about, they're going to let the federal government tell us what to do. Tennessee is going to lead in its own direction. So why wouldn't we want to take our own mental health issues and take it by the hand and be a leader on this and make sure that we understand that all of our Tennesseans have access to this and can have this particular benefit?
Thank you. Thank you.
Representative Mitchell.
Thank you, Madam Chair. Correct me if I'm wrong. I'm thinking you're looking at this like the annual visit. Like each year I can go annual visit. That's zero. I don't have the copay.
Correct. That's
Okay.
it. That's all it is. It's just
And sometimes, you can either look at it as a mandate or it can be a cost saving measure. I think a lot of the cancer screenings we have in the state, the insurance industry fought those over and over, but in the end, they're probably cost saving measures for the industry now. Because as the presenter said, you can catch something early. Well, you can catch something early, hopefully in mental health as well. And either we can catch it before they have to, someone may be hospitalized, or before they do something that, the cost is greater than we can determine in dollars. But I don't see a problem with this. I think the industry I think it would probably help in the industry, because right now we have so few providers that are in network for mental health that this would push a lot of the providers to get in network, so more people would step up and get those checkups regularly. And I think it would lower the cost of those visits over time as well. Thanks.
Chairman Terry?
Can I respond before you move that?
Yes, you may. I'm sorry.
Just really total transparent, it's like, I don't mind telling anybody, yes, I see a therapist, but in order for me to get to seeing that person, I had to find that perfect person that was a perfect match for me. It wasn't on the first phone call that I made, and it was like, yeah, I think it was good. It was an interview process, just like picking your primary care doctor. You have to have that comfortability with that person. And so this is an opportunity for people to have someone in case a crisis arise, which it seems to be happening. Sometimes people break in different ways, and sometimes I think this can help in a lot of ways. But I'll stop there. And
Thank you. Chairman Terry?
Thank you. I think some of my questions were answered a little bit earlier, but I just, if somebody's getting referred for this, is that being denied? Do we know like if you go into just a wellness visit for yourself, physical and all that, and then your doctor refers you, is that visit getting denied? Do we know?
not to my knowledge, but I do not have any information saying, or statistics saying whether they've been denied or not.
Okay.
Chairman Terry?
And for this annual visit, do you know if it would telehealth fall under that, or they could get do this under telehealth visits?
I think if it could fall under that, it doesn't specifically say that, but I think if that's one of the already improved things, I think this would be a great way to improve it, to use telehealth.
All right, thank you.
Any further questions? Seeing none. All those in favor of sending House Bill 2104 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full.
Thank you, Madam Chair and committee.
Item number 4 is House Bill 1826 by Chairman Martin. We have a proper motion and second. Chairman, you're recognized on the bill.
Thank you, Chair, Lady, and committee. As a healthcare provider, this is a type bill that I like to see. It deals with our chronically ill children, finding solutions to that and getting them out of the hospital quicker. It takes into account the ethical and moral component of addressing that. It takes into account the cost effectiveness and savings amount that can come into play as we do that. And then also just the fast, effective aspect of getting that child out of that environment as quick as possible. What I'm talking about is using rapid whole genome sequencing in that process. So what that is doing, it is taking children with chronic illnesses who are possibly sitting within our NICUs and PICU units. We're able to use this screening to identify the condition earlier. So when we do that, typically with a chronic illness, you can have 5 years of undiagnosing. It goes that long on some of these children and some of these individuals. They'll see 7 or more different specialists during that period, trying to receive an accurate diagnosis. During that period, once they are given a diagnosis, oftentimes 40% of those are misdiagnosed as well. And that continues to cause a burden on the family and as well as on the child and then on our TennCare system. Currently, a lot of these children that fall under this category, they are in the NICU for 16, 18, 24 months at times. All that is calculating and figuring numbers. With this genome sequencing, we're able to go 7 days or less to get that actual accurate diagnosis and help that family. So if you look at it from that magnitude, if we have a 16-month process, typically we can use this genome sequencing, get the idea of what's going on earlier, and then get that child out of the care with the proper diagnosis and on their way at a faster rate. This reduces healthcare costs. It avoids invasive procedures, reducing hospital cost as well during that process. Currently, there's 11 states that are utilizing this service. Just recently, Florida did a pilot study, as well as Michigan's pilot study. Florida alone, it saved $2.8 million for their Medicaid system by implementing this. So last year, they signed this into law down there to make that the normal for this process. So that portion of it comes into play, again, to address the true need of getting those kids the care they need as fast as possible. With that, Madam Chair, I do have a special guest, expert witness that would testify as well, but I could also answer questions before that based upon the committee.
It's Dr. Terry Finkel from Le Bonheur Children's Hospital. We will now go out of session to hear from her. Yes, that's perfect. Yes. Please state your name and who you're with for the record, and you have 3 minutes and 30 seconds as you requested.
Thank you. Good afternoon, Madam Chair and members of the committee. Thank you for this opportunity to speak about this important issue for the children of Tennessee. I'm Dr. Terry Finkel. I serve as Vice Chair of Pediatrics at the University of Tennessee Health Science Center and Vice Chair of Clinical Affairs and Chief of Pediatric Rheumatology at Le Bonheur Children's Hospital. But today, I'm here as a professional scientist and clinician with over 30 years of experience doing research and serving children across the globe. I care for children from birth to 21 years of age with diseases of the immune system, some mild, but many life-threatening. Madam Chair, members of the committee, imagine the fear and frustration of your child, spending the first 5 years of their life in and out of the hospital as doctors try to find out what is wrong by trial and error. Now consider those years reduced to days. This is the promise of House Bill 1826 and rapid whole genome sequencing in children with rare diseases. You may be wondering, what is rapid genome sequencing? Our DNA contains thousands of genes with instructions for the human body. Genome sequencing finds specific genetic changes in the DNA that cause a child's illness. Rapid whole genome sequencing is a test that does this within days, returning results rapidly so we, as physicians, can intervene quickly. Who should we test with rapid whole genome sequencing? Rare disease impacts 1 in 10 people in the US, over half of whom are children, and 80% of rare diseases have a genetic cause. The children we test will be the sickest of the sick, who need answers fast. This technology can be thought of as a powerful magnet to find that needle in a haystack and rapidly pinpoint the exact cause of that child's illness. Finally, how is the benefit of rapid genome sequencing measured? First, in the diagnosis. Now we know what the disease is, and importantly, what it isn't, among a long list of possibilities. Second, change in management. Now we know what to do to help that child and what not to do, like repeat expensive imaging or exploratory surgery. And third, improved health outcomes. Think about a baby with nonstop seizures. With this test, the doctor is steered toward the right drugs to prevent brain damage. Then think about how this translates into quality of life. A child being able to feed themselves, to walk unassisted, to go to school, to plan to go to work and have a family. And then beyond these health benefits are important economic benefits, some of which we've been discussing today for our healthcare systems. Studies show cost savings associated with not spending money on lengthy intensive care unit stays or repeat hospitalizations. In conclusion, thank you, Madam Chair and the committee, for the opportunity to raise awareness about who these children are and what their families experience. We have incredible technology, and it will only rise in value as we diagnose more children and improve our understanding of these rare genetic diseases. We appreciate your consideration of this bill and your commitment to improving efficient, effective healthcare for our children of this great state of Tennessee. Thank you, and I'm happy to take any questions.
Thank you, Dr. Finkel. Does anyone have questions for Dr. Finkel? Chairman Terry, you're recognized.
Thank you, and appreciate you for coming and testifying, and just wanted to welcome you here. It's been a hot minute, but I trained at Le Bonheur probably when you were there, probably when I trained as well. Worked with Dr. Cancio and Dr. Ernst, and there y'all do great work. And just pointing out that the cost on the front end is saved on the back end by getting these people help and getting the kids diagnosed early and getting into treatment. So again, thank you for coming and testifying. I'm going to support your legislation.
Thank you, Chairman Terry.
Representative Himmer, you're recognized.
Thank you, Madam Chair. Just curious if these tests that we're talking about experimental or investigational in any manner?
No, these are they will be standard of care within the next few years, I believe. These are clinical tests. These are CLIA, what's called CLIA approved clinical tests. They are currently orderable, but they are almost always not approved by insurance companies or by TennCare. And we cannot order them in the hospital because of the extra cost. These tests, the whole genome sequencing is no more expensive than an MRI, but because they are not on an approvable list, the hospital won't allow it to go forward in general. I've never been able to order this test in the inpatient setting.
You recognize.
I see the legislation talks about the evidence-based criteria for this and the things that come to this, but I know the technology on these tests are changing so rapidly. I mean, how are providers like yourself finding out these things are available and making sure they are the appropriate kinds of testing?
That's a very good question. We rely on experts, myself, our geneticists, people who are in this space, and it is promoted by the hospital if we can pay for it. We are not encouraged to order. Physicians are actually very fiscally responsible, and we give strong, long consideration to this type of testing. In addition, we have in most larger tertiary quaternary care, the high level children's hospitals, there are organizations, committees that are dedicated to adjudicating genetic tests. It's called PLUGS, and this is national. And the PLUGS committee is currently involved in determining which genetic test can be ordered on which child or should be ordered on which child. And there is a national effort to embrace rapid genome sequencing in the context of PLUGS. So this is an ongoing process. There will be, I believe, governance around this. This will not be all children in the NICU, all children in the PICU. This will be very well considered beyond the limits or the guidelines presented in this bill.
Thank you.
Any further questions? Okay, seeing none, we will now go back in session. Thank you for your testimony.
Thank you, Madam Chair.
Chairman Martin, you're recognized for final comments.
Oh, ma'am, thank you.
Okay.
That's a great presentation.
Question has been called. All those in favor of sending House Bill 1826 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full. Item number 5 is House Bill 1985 by Chairman Martin. Would you like to roll that?
Oh, yes, after speaking with committee and members, I'm going to roll that for 1 week.
Okay, without objection, we will roll it 1 week. That completes the regular calendar. Now we will take up the addendum. Item number 1 is House Bill 949 by Chairman Boyd. We have a motion and second. Chairman Boyd, I see you have an amendment. Can you verify the drafting code?
Madam Chair Lady, that amendment drafted code is 010288.
Okay, and I think that rewrites the bill, so we will go ahead and vote on that and okay. There's a motion and a second. All those in favor of the amendment, signify by saying aye. Opposed? The ayes have it. The amendment is on the bill. Chairman, you're recognized.
Chair Lady and Committee, House Bill 949 is a wonderful bill. It is brought by the Tennessee Dental Association after surveying the statewide group of dentists and finding out some of their top issues. This bill will ensure that dentists are paid correctly when they perform the procedure for their patient. It cleans up areas of code where dental insurance carriers and dentists alike have conflicting implementation of the law, and we've worked with all major insurance carriers on the bill. Madam Chair Lady and Committee, I'll take any questions.
Do we have any questions? Question has been called. All those in favor of sending House Bill 949 to insurance full signify by saying aye. Aye. Opposed? Ayes have it. Bill goes to insurance full.
Thank you, Madam Chair Lady and Committee.
That concludes our calendar. Before we close, do we have any announcements? Do I have a motion to adjourn? We are adjourned.